gentlemen, I appreciate Professor Ibrahim Mustafa all the way back for his and the organizers kindly. I'm going to talk about a difficult topic, refractory reflux. How common is the refractory reflux and how to deal with those? The first problem starts with the definition. What is refractory GERD? You see, recently, I think it's not working. Okay, recently, this one is working? Okay, thank you. That's fine. Recently, in our Turkish Journal of Gastro, we published the reflux consensus, and it's coming from our consensus group. What we are saying is, what is the definition? If we have a patient without alarm symptom, we put them on single dose of PPI, but standard dose, not the half dose, for 4 weeks. If they don't respond this, then we increase the dose to the double. Within the additional 4 weeks, if they don't respond this dose as either, then we define it as the unresponsive patients. This is how we define it. But, generally we ask the patient, are we happy with your PPI? And what is the happiness with the PPI? This is a very standard slide coming from Peter Kahilas. What he's saying that this is the heartburn relief in patients with esophagitis and NERD and regurgitation relief. According to his data, those group with red arrow, they do not respond to PPI. More than that, those are patients with atypical symptoms. They don't respond to PPI at all. But this paper criticized with many ways. First of all, Peter collected all the patients from all the studies, and we don't know how those patients evaluated. This is my data. We look at our patients, what we see, and we look at the different phenotypes of reflux disease. I'm going to mention them later on. In the typical patient with erosive or NERD, non-erosive reflux disease patients, PPI unresponse is about 20%. But my friends, we have a problem here. With either esophageal hypersensitivity or functional heartburn, about 40% of our patients do not respond to PPI. This is the problem. Why they don't respond? There are many reasons. I'm going to talk some of them. We have diagnostic problems, regurgitation, which is very important, hypersensitive esophagus, functional heartburn, acid packet, weak or non-acid reflux, extraesophageal reflux disease. I'm not going to talk about this, but this is a nightmare for sure. Psychiatric comorbidities and coming all the way like this. Okay, we have at least 18 different reasons. We are supposed to evaluate for all possible reasons, and I'm going to talk how we evaluate those patients. First of all, is it really reflux? Or it's something else? It's the mixture of reflux, such as the, here, irritable bowel syndrome, mainly it's confused with dyspepsia. Patient tells that I have a dyspepsia, and then if we tell them you have a reflux disease, the majority of the dyspeptic patients do not respond PPI therapies, at least 60% of them. This is the one, if patient comes to me and saying that, Doc, I have a reflux disease, I do not respond to PPI, first thing I ask, what do you mean with reflux disease? And another problem, it's our problem. It's your problem. It's not the problem of Western countries, which is regurgitation. When we look at the data, that's our study from Turkey. That's the study I performed with my Russian friends. You see, in Western countries, predominant symptom is heartburn, but in Eastern countries, predominant symptom is acid regurgitation. We regurgitate, there's a volume here, and PPIs are not pretty bad in this symptom, as you see in the slide. PPIs are much better in the symptom of heartburn, but not in the symptom of regurgitation. This is another limitation. I add, which I'll talk about later on, but I add alginate in many of those patients as well. How about the others? Slide is not moving. Are you going to add 1 more minute to my talk, dear Chairman? Thank you. Okay, now what are the diagnostics in such case? First of all is the PPI test. And then we have upper GI endoscopy. We have high-resolution manometry. We don't use the regular esophageal manometry anymore. We have 24-hour pH impedance. We don't use the regular pH anymore. We have wireless capsule monitoring, which is a lovely technology I use especially in patients with non-cardiac chest pain to monitor the patients for longer time frames, up to 8 to 10 days. I can keep this capsule here. I don't use radiology at all, except I have a suspicion for achalasia, no place for scintigraphy, and for the LPR, we have something, we have ENT's eyes, we have laryngeal pH monitoring, and we have PEP test, which is a new technology. Now we have different modalities. That means there is no gold standard in reflux disease, which we know it. How about the endoscopy? Endoscopy is good in whom, but in a patient such as this one, eosinophilic esophagitis, I have a question to the audience, if you don't mind. How many of you have seen one single case of eosinophilic esophagitis in your life? Could you please raise your hands? Yeah, like Turkey, we don't have it. It's very rare. Have you, any of you see about 20 cases at all? No one. It's very uncommon in our part of the world. Achalasia is a confusing situation, like the here, a Barrett cancer. One of the things is we are supposed to perform, for sure, high-resolution manometry for the PPI unresponsive cases in order to exclude achalasia. Because achalasia absolutely mimics reflux disease, and they do not respond to PPI. In that case, we are supposed to perform high-resolution manometry. And please, please, we need more and more motility centers. We need more interest for such cases. Why achalasia confuses? I'm not going to go to the details, but in many achalasia patients, heartburn, we see heartburn. But if you have a patient predominantly with dysphagia, but with heartburn, and if they don't respond to PPI, please keep in your mind this patient might have an achalasia. If you don't have the motility, then in that case, you can refer to the barium swallow. That's another option. How about the other stuff, like the 24-hour pH impedance monitoring and all those things? Okay, let's come this one. Now we have 24-hour pH impedance, okay, because now in such technology, we can show the role of non-acid weak acid reflux. We can evaluate the mucosal health by using the baseline impedance, and new metrics are coming. Then, because if I aspirate a material with pH 7.5, I still cough. Especially in patients with atypical reflux symptoms, you need 24-hour pH impedance with such a tracings. For example, in such tracings, this patient has a reflux episode, but there is no acid here. Then there's non-acid reflux episodes. And in some patients, those episodes are responsible still from the reflux symptoms. Then they do not respond PPI because there is no acid. How can they be responsible from the PPI? That's another problem. And also, if I have a patient with resistance to PPI, one of the first things, I put a double pH probe, 24-hour pH impedance. I put one into the stomach, one into the esophagus, and then I evaluate the data. What we know from the data is PPIs do not decrease the number of reflux episodes. If patient has 150 reflux episodes, this patient will still have 150 reflux episodes, but this patient will have less acidic number of reflux episodes, but mainly non-acidic or weak acid reflux episodes. Still, we look at the symptom reflux association in such cases. PPI metabolized hypermetabolization is another trouble. It's very common in Turkey. About 70% of our population is actually hypermetabolizer. This is the problem. In order to exclude such possibility, I suggest you to move mainly with the rabeprazole or second choice, esomeprazole, because rabeprazole is the clearing from this liver is a non-enzymatic pathway, then maybe you can rule out the possibility of hypermetabolized patients. Let me show you two tracings. This is not a hypermetabolizer patients. This is the intragastric pH. See, those are less than 4, intraesophageal pH. When we put the patients with a standard dose of PPI, we were expecting such a nice tracings higher than 4 here. This is a regular case. Still, stomach is still full with acid, and inhibition is very irregular. Esophagus is okay, but stomach is not okay. Then please do not expect such a full acid inhibition in any of your cases. This is very uncommon to reach a very high acid inhibition with standard dose of PPI. Now we have two different phenotypes. This is the first one. You see, this is the distal esophagus, proximal esophagus. The patient pressed the button whenever he or she feels heartburn. And 24-hour measurement is normal. There is no pathologic acid exposure. But you see, he or she could detect all of them, except only this one here. There is no reflux. Wow, this is a very hypersensitive esophagus. When we look at the whole data, you know, it's very interesting. She feels 19 out of 22 reflux episodes, which is very uncommon. Everybody in this room had 75 reflux episodes within last 24 hours. All of you, up to 75. If you don't have the reflux disease, you don't feel it. But this patient feels the normal. We know it from the SAP and SI. We call it reflux hypersensitivity. It's another example. This patient defined reflux symptom 26 times. Only one symptom is related with reflux. There is no reflux, but this patient still feels it. This is functional heartburn, nightmare. The worst case scenario, if surgeons operate these patients, they will be in trouble for sure. Why? One of the reasons, psychiatric comorbidity is so high in GERD patients, this is one of my studies, but especially in patients with functional heartburn and esophageal hypersensitivity. Those are percentages. Please look at the numbers. Psychiatric comorbidity, at least in our hands, we are running a tertiary referral center, is as common as irritable bowel syndrome. Then in that case, I am supposed to use some other medications. We call them neuromodulators. It's my third most common medication. I use PPI, I use alginate, and I use many neuromodulators, mainly tricyclics, especially here, in that case, amitriptyline, but very low dose. Remember, we don't need high doses like antidepressants. We need very low dose, and explain the patient very well what is wrong with that. Another point is we recently defined acid packet. If we have a food, acid secretion actually increase following the meal, and acid accumulates here. If I put a pH catheter here, and if I pull the catheter slowly back from the stomach to the esophagus, what I see, there is an acid here, there is a food here, and acid packet here. When reflux occurs following the food, which is very common, then this acid goes up. This is why we always have acid reflux following the food, not the weak acid or non-acid reflux. In this case, what we do, we initiated alginate. This is our very recent publication. We wrote such a huge supplement for the alginate. What we know from that, alginate actually produce acid packet here on top, a raft here on top of the acid packet, and protect against reflux. With some in vitro data and with some in vivo data, you can see it here. We use 4 grams of alginate half an hour after the meals in patients with PPI unresponsive, especially in patients with atypical reflux symptoms. H2 blockers, I don't believe them. Very rarely I use them. I use them in patients with nighttime reflux because they inhibit for the nighttime acid production. Okay, because 50% of my patients will resist to the H2 blockers within 2 weeks. This is why I very rarely use H2 blockers in combination with PPI. We have many, many pro-motility drugs. I don't have time, but I suggest you to read this nice paper. There are many, many motility drugs now. We use domperidone. They don't die because of the heart problem, I can tell you. And I started to use prucalopride recently in many patients, especially if they have a constipation. I combine them. And we need more prokinetics, that's for sure. But it's another option, we can combine them too. This is a very recent study published, not presented in DDW. Michael and his team, they look at the bile sequestrant, and they found very good response. This is a possible future medication for us. I'm really looking forward to see the further studies in bile sequestrants to, absorb the bile inside the stomach. Another new medication is vonoprazan, potassium competitive acid blockers. Those are also an interesting medications. Studies started with the HP, and recently this one came out, esomeprazole versus vonoprazan, and the results, and this is a Japanese drug, initial results show that vonoprazan actually better than esomeprazole. But many studies all supported by the company, and we need new studies, bigger studies, whether they are really pretty good or not compared to our current PPIs. Yeah, GABA group, lesogabaran or others. I think we are pushing for nothing. I have a limited personal experience because of side effects. We keep talking about those medications, but they never work well. This is why I put those slides, but I'm not a fan of those. But that's another possibility in PPI refractory patients to combine in the combined therapy. Then, in the last, what should I do in a patient with PPI resistance? Is it really GERD? I check for overlapping disorders. I ask for alarm symptoms. There might be a cancer. Okay, this is why I always check for other diseases. Poor compliance to therapy. I ensure the patient to compliance the drug. I ask, when do you take your medication? They should take at least half an hour before the breakfast, or the double dose half an hour before the dinner. That's very important. And at least 3 out of 5 PPIs lose 50% of their effect if they are taken after the meals. Unoptimal dosing, if dose does enough, then I double the dose. I don't mind double the dose at all. Even the effect is not linear, but I always double the dose in such patients. And sometimes I add prokinetics, I add alginate. Surgery endoscopy is a good option for the inadequate control of acid secretion. If I have a patient with reflux other than acid, weak acid or non-acid, then add alginate, as I discussed, baclofen, maybe, but in many patients, I add prokinetics. One of the major reasons is the visceral afferent hypersensitivity on such, especially in patients with reflux hypersensitivity and functional heartburn, I add tricyclic antidepressants. Psychological problems is very common in my practice, very common. They look at the Dr. Google and they come and say, doctor, when I'm going to have a Barrett esophagus, I don't have intestinal metaplasia in my esophagus, still do I have the risk for Barrett esophagus? I have such cases. They have PhD in reflux disease. And I'm supposed to really ensure them, and I add them antidepressants, and I consult them with psychiatry. Extensive metabolism, I increase the double, and I also combine them. Delayed gastric emptying is very rare. In that case, I add domperidone, 30 milligram, not higher than that. If I have a gastro, I always ask for solid phase for our gastric emptying test. I'm not going to talk about the esophageal reflux disease, and for the regurgitation, I always add main alginate and I add prokinetics. Sometimes I add H2 blocker if there's no heartburn, but if the predominant symptom is regurgitation. Okay, and that's the summary group. Thank you very much.